So good afternoon, everybody. First of all, I would like to thank the organizers for giving me the chance to share with you our data on AML targeting by CARs. So, as you may all know, AML is still represented by a high unmet clinical need, and it is one of the main blood cancer types associated with the lowest survival rates, and with more than 50% of patients relapsing after the first therapies. And, but after almost 40 years of unchanged treatments, luckily, research has moved forward in the last decade, and this is mainly due to the discovery and to the better deconvolution of the AML biology, and in particular the identification of leukemic stem cells which are chemo-resistant and are responsible for the recurrence of the disease, has prompted researchers in trying to find more targeted therapies, and in order to eliminate not only the bulk AML but also these residual leukemic stem cells. And in this context, CAR T-cell therapy could represent a really promising approach. And here you see a timeline of anti-AML CARs research, and you can see that we were the first pioneering group trying to exploit this strategy in the AML targeting, starting from 2010, and targeting the CD33 and CD123 tumor-associated antigens. Here you see other preclinically validated targets, and some of them have reached the clinic and some of them are close to the clinic. And, but evidence is accumulating in all these years in the CAR T-cell field has suggested us that we are dealing with a really powerful tool, but a really careful preclinical evaluation has to be done in order to really match efficacy with safety. And as living drugs, CAR T-cells have to be considered as different variables that have to be interconnected together, and they have to play all together in order to get an optimum product. For example, the T-cell type to be redirected by CAR has to be safe and to persist, and also the gene transfer technology that should be safe and feasible, and the manufacturing that should be not time-consuming and also feasible. And moreover, considering that CAR T-cells, to match efficacy and with safety, we have to really consider them in a context-dependent manner. And in order to translate the successes that we obtain with CAR T-cells in the B-cell malignancy field also to AML, we have to consider that AML is really a challenging disease because it has intrinsic characteristics, such as we don't have a tumor-specific antigens today, and so we could have an off-target toxicity, and also there is an immune suppressive microenvironment that could lead to tolerance or exhaustion of CAR T-cells. So we have to take these variables all in consideration, and all these gears have to play together in order to have a good and high-performance machinery. So today I would like to talk to you about our CAR T-cell strategy we developed in the last years in our center, and the implementation that is currently ongoing on this strategy. So first of all, our group has invested a lot in the use of cytokine-induced killer cells as effector T-cells, because they are easily expandable cells from PBMCs, and they share some functional properties with natural killer cells, such as a non-MHC restricted cytotoxicity against several tumors. They have a minimal GVHD, and they are able to reach leukemia-infiltrated tissues. And we had the opportunity to test them clinically in the context of patients relapsing after transplant, and we were able to see that these effector T-cells are feasible, are safe, and well tolerated also in the haploidentical setting. So concerning the gene transfer technology, we moved from the viral vectors that you have heard a lot in these days. It is a really powerful technology, but it's also cost-effective, and time-consuming. And so we moved to the non-viral gene transfer technology by using transposons, and specifically we are using the Sleeping Beauty platform. Because transposons are easy to purify, they have been shown to be non-immunogenic, and they have a random pattern of integration. So this is our platform that we optimized. So we were able to keep the 21 days of CIK, typical of CIK cell culture, and you coupled this differentiation with the nucleofaction of PBMCs in order to insert these two plasmids. So the transposase SP11 that encodes for the enzyme that recognizes specific elements on the transposon and is able to stably integrate the CAR cassette within the genome of T cells. So we were able to obtain a good percentage of CIK cells at the end of the culture, and this protocol is actually ongoing in our institution targeting CD19 B-cell malignancies. So as concerning the target antigen choice for AML, we focused the attention on the CD33 and CD123 tumor-associated antigen because they are well conserved, and as you can see, the majority of the patients are overexpressing these two tumor-associated antigens, also at the relapse, and mainly, most importantly, also leukemic stem cells are overexpressing these two antigens. And all these antigens are well conserved and expressed within all the FAB subtypes of AML. So these are our preclinical data by using the retroviral system. So we were able to demonstrate both in vitro and in vivo that CD33 CAR and CD123 CAR redirected CIK cells were able to mount and to control the AML disease both in vitro and in vivo. And then we moved to the non-viral gene transfer technology in order to offer this strategy to treat primary induction failure patients or chemotherapy refractory AML patients by using, for example, autologous CAR-redirected CIK cells or partially matched donor or cord blood-derived CAR-CIK cells. And also another clinical setting would be patients relapsing after transplant. So in this context, we are also collaborating with Professor Itzvak in Germany in trying to optimize our non-viral platform by using a novel hyperactive version of the transposase that is called SP100X, coupled to a new version of the transposon, the PT4. And a poster has been selected here at this meeting and has been presented yesterday, but briefly I would like to show you our data. So by using this novel combination of SP100X and PT4, we were able to obtain, by lowering the amount of transposase for the integration of the CAR, we were able to achieve higher CAR expression levels, both in terms of percentage and MFI. The pointer is not working anymore. And with the two platforms, the CD33 CAR-CIK cells were both able to be specifically active against the primary AML cells and also cell lines in terms of cytotoxicity, and also there was a specific cytokine release and proliferation upon target antigen challenge. So moving to the in vivo part, we developed two different PDX in vivo models. So the early treatment model, in which the CAR-CIK cells are injected early after 5 days from the AML injection, and then we were able to see that CAR-CIK cells are able to control and to reduce the AML development in all the districts analyzed in the bone marrow, peripheral blood and spleen. We were able to see a direct correlation between the expansion of CAR-CIK cells and the control of the disease. And here I show you that this is the phenotype of CAR T cells ex vivo from the mice, and we could still see the typical CIK cell phenotype and also a good memory phenotype of central memory and effector memory cells. So in the second model, the leukemia treatment model, we started the treatment when we could see a clear bone marrow engraftment in our mice. And also in this case, we were able to see that CAR-CIK cells were able to delay the AML progression in the district analyzed, and we still see this correlation between the expansion of these cells and the control of the disease. And here I put an example of the CAR expression by flow of these ex vivo CAR-CIK cells. So in search of the simplification and in search of less cumbersome and more robust cell production processes, we are trying to develop an off-the-shelf therapy. And we would like to use the cord blood-derived CIK cells in collaboration with the Professor Rambaldi and Dr. Introna in Bergamo, who demonstrated that CIK cells can be easily derived from cord blood from partially matched donors, and they are safe and well tolerated in patients. So this is our platform. So we would like to start from cord blood and then use the non-viral gene transfer technology. And the poster has been selected also and presented yesterday here at this meeting. But briefly, these are our preliminary data. So we were able to get up to 50% of stable CAR expression on cord blood-derived CIK cells. And this cellular product was also really specific in killing AML cell lines. And here I depicted only an example of 4-hour co-culture of cord blood-derived CAR CIK cells together with AML targets, and you can see that the AML target is eliminated. So, as I told you before, it is important to consider the AML disease and all the challenges that are related to this disorder. And the preclinical, the first preliminary data from the clinic are suggesting us that we really need to boost CAR-Ts against AML and to improve them in order to get a higher potency and persistence, because we still don't see a clear anti-leukemic response. And also we have to deal with such an immune suppressive microenvironment that could lead to the exhaustion of our T cells. So, moreover, we have to deal also with the potential adverse events such as myelotoxicity or off-tumor effect, given that we don't have still a tumor-specific antigen. So among the different alternative and innovative strategies that are actually ongoing preclinically in order to boost CAR T cells against AML, we decided to invest on the dual target strategy. And Dr. Perriello today presented our preliminary data, but only shortly briefly telling you that we are trying to use a trans-signaling strategy. So in order to get the real activation of our cells only when the two targets are co-expressed. And we will make use of our knowledge of affinity mutants in order to lower the signal 1 to get an attenuated signal 1 in order to spare the toxicity against normal tissues such as endothelium. And we are also starting to see the double CARs also in the clinic. So from ASH 2011, we had this promising data. So from the first case targeting CLL1 and CD33. So there are, in this case, this patient was treated with this compound CAR, and after 20 days post-CAR infusion, we could see the total myeloid ablation. So there is more to do, but we already have some preliminary and promising data about this double targeting approach. So to conclude, that there is an unmet need in the context of AML targeting, and CAR T-cell therapy could represent an innovative strategy. So our non-viral ZIP-in-beauty modified anti-AML CARs have shown to have a potent anti-leukemic activity, and we are approaching these off-the-shelf cord blood-derived CAR CIK cells in order to simplify the process and to maybe make these cells already and immediately available for the patients. And in general, we are leaving the results of a first wave of CAR T-cell therapy, but especially in the context of AML, I think that we really need to design more smart and reasonable CAR T-cells. So I would like to thank my collaborators, especially Dr. Roti, Silvia Arcangeli, and Dr. Perriello, who worked with me in these years in the AML targeting by CARs, our collaborators, and all of you for the attention.
So thank you, Sarah, for this very nice presentation. Are there any questions from the audience? If not, I might start. Oh, okay, there is one. Perfect.
Might have a question. Do you expect the partially matched CAR sick cells to persist, or do you anticipate using this as a bridging regime to transplant, presumably?
I mean, in the context of AML, for sure, the best clinical setting to prove our CAR T-cell targeting is the bridge to transplant, of course. In terms of persistence of these cells, this setting could allow us to check the persistence of these cells, and of course we are also working in the in vivo setting in our mice models in order to see if, for example, different co-stimulation could help in helping in persisting of these cells over time.
Yeah, but the mice are not going to be able to reject the cells. Humans might.
No,
So
yes.
just give me your hunch. Do you think they'll persist?
Yes, I mean, they are well tolerated and they persist. And so also in the non-manipulated and non-CAR, in the normal CIK cells, they persist in patients. And so also in the upper identical setting. So in this case, we added the CAR, so probably these cells will respond to the target and they will expand and proliferate.
Actually, I also have a question, Sarah. What about the on-target of tumor activity of your CAR T cells? Do you observe any, and what do you think about that?
Yeah, so we know that we are dealing with these two tumor-associated antigens that are shared, at least the CD33 with the normal myeloid compartment, and we had the opportunity to check the potential toxicity so for the CD33 targeting and also the CD123 in our preclinical work with the retroviral vectors, and we were able to see that our CD123 was able to better spare the normal hematopoietic stem cells. But we know that CD123 is expressed at low levels also by endothelial cells. At least now from the clinic we don't see any kind of toxicity against endothelium, but for this reason we are trying to do this transsignaling CAR technique in order to try to spare the normal tissues and to be, of course, to get the efficacy, but to match the efficacy with the safety.
So thank you again, and let's move to next speaker.